Hi, everyone. Gene Santucci here, emanating here from south of the San Francisco airport near Stanford University. And welcome. We'll spend some time together. We won't get deep in the weeds on some of these topics as I would normally do. And so I'm an associate professor at the University of the Pacific, have my own private practice in Atherton, California, and do these interventions across the country through Catapult education. But basically, I'm a wet finger dentist. I'm a general dentist, wet finger dentist, the way most of you folks are out there. And about 8 or 9 years ago, since I was doing a lot of TMD work, I got excited with sleep. And this has kind of taken over a lot of what I do, even though I still have a general practice. So again, I want to compliment everyone for what you do for the people out there. The general dentist, the hygienist, we're fantastic at taking care of the oral condition. We're fantastic at taking care of pain and inflammation, fractures, this and that. And you do a fantastic job. I want to add to that just a little bit more and say, what if we can add to what you now do in a very, very simple fashion? And we're able to not only take care of all those things you do so well, but also to perhaps extend a patient's life. Or in a case of children, maybe getting them off medications like Adderall, et cetera. Why wouldn't that be such a fantastic thing to feel? And we can do it. So we're going to cover some of those things today. Here are some of the course objectives. Understand the difference between healthy and disturbed sleep. We'll give you some background in that. Consider some comorbidities evolving from disturbed sleep. What do we see in the mouth? Discern these oral effects, the result from Gerd's, erosion, Bruxing, and sleep apnea, and then understand the role in the prevention and treatment of these noxious effects on the acid that a lot of this brings up on the oral environment. I know there's a lot there, but we will try to get through this as possibly as we can. These are some of my educational partners that help support and bring a lot of this to fruition. And a lot of the products that I do use are the products from these people, and they're specialized in certain cases that I use them, especially in high acid conditions. So this is who I am. What started all of this was about in 2017, a policy came out from the ADA saying, hey, guys, we need your help. We want you to be gatekeepers. There's this pandemic coming across the country. People aren't sleeping well. It's having an effect on their total health. And the physicians just don't have time to deal with this. Now, as you recall, the ADA has come to us previously. They came to us when they're talking about fluoride, and we did a great job. You guys did a great job with fluoride. They came to us and they say, hey, we need someone to really do a really great head and neck exam, cancer examination. And we've done that, and we've been fantastic at that. And this is the new one. They said, we would like you very simply just to add to your intake exam a short little survey on how people are sleeping. And if they score high, just tell them, refer to their primary care to have a sleep study done. It could be that simple. And these little surveys, I'll show you them, can be both for children and adults. And then they said, if you want to get involved with eventually treating these patients, there are courses available, so many residencies, and I'll mention that. We have one at the University of the Pacific, and then you can actually start treating these patients. So this is when it all started. So let's get into the weeds a little bit. What is sleep? This is a definition out of the, Encyclopedia Britannica, if they still have that. It's a naturally occurring state characterized by reduced or lacking consciousness, relatively suspended sensory activity, and inactivity of nearly all voluntary muscles. Now, if you're there and you're asleep, someone can come and bonk you in the head. You have absolutely no idea what's going on. You respond quickly, but it's not like a hibernation or a coma that we go into, thank goodness. And that good old alarm clock is always there reminding us of that. So this is kind of the normal definition of sleep. So what do we see going on? It's sad. 2/3 of the world's population has some form of disturbed sleep pattern. 2/3 of the world's population. People dying in their vehicles because they're falling asleep is greater than those combined from alcohol and drug abuse combined. Now, have any of you, you're driving, you're going 65 miles an hour and just, man, if I can just close my eyes for a sec, you get that, and sometimes your head bobs a little bit. How long do you think it's going to take you, if that happens, to go in the opposite lane and hit some oncoming traffic? Very easy to do. And many of these people dying, if they don't have alcohol or drugs in their system, they kind of think it was a suicide. But I just think a lot of these are subject to people just falling asleep at the wheel because they haven't been sleeping. So what's going on? So we're fatigued. So are our patients. When I interview my patient, hey, how you doing? It's nice to see you. What's going on? Oh, I'm just fatigued. I'm hearing the word fatigue more than tired or anything else. And it's a sense of I'm tired, but I'm not tired. I don't have that get up and go energy I used to have. Something isn't right. So should we be concerned? Should our practice be concerned? And now we're getting this idea that perhaps we are the gatekeepers that can help some of these people. So the ADA is asking for help. Why dentistry? Well, we're totally trained in doing a head and neck exam. And many of the things that we see in the oral cavity evaluation are signs and along talking to the patient, symptoms that they're just not sleeping well. The intraoral exam is our sandbox. Physicians, you go to physicians, bless their heart, they open your mouth, they put that stick in your mouth, say, and 2 seconds later, they're done. We are so much more in depth with the exam. And I think the ADA recognizes that, and that's why we can be such a help to the profession. MDs, as I said, don't have the time to do this, so they're looking to us for at least be this gatekeeper that can refer patients to the proper areas. Now, this is a sample, and you can get this online. It's a very simple survey for adults, and you just add that to your intake exam or when they come in, hygienist, when they come in for their hygiene appointment. And they fill this out. Very simple, stop, bang. It has to do with, do you snore, yes or no? Do you feel tired during the day, yes or no? Has anyone observed you stop breathing or heavy snoring while asleep? You are taking blood medication for high blood pressure, taking medications, yes or no? What is your BMI? And the reason why I like this particular exam is because the BMI scale is right on the chart itself, so you don't have to get your abacus out to figure that out. Your age, are you 50 years or older? Neck size, 17 for male, 16 for female, and is your gender male or female? And then it ranks it for you, how many yeses you get, if you're significant or moderate to severe. And then what I do is I have them sign it, date it, and then I sign it also. And then I give them a copy of this. So I give them a copy and say, here, take this to your primary care physician and tell them you're scored high on this, you're talking to your crazy dentist, and he would like you to have a sleep exam, a sleep survey done. So they will set up the sleep survey for you. They will set it up either going to a sleep facility, or many more people are now having at-home sleep studies done. And we'll get into that in a little bit. But this is a real nice one. You just download it from the internet. So why do we sleep? We know why we eat and drink and reproduce, but why do we sleep? If you stop and think about it, that's a third of your life you spend, sleeping. And Reschnaufer, I'm sorry about the pronunciation, said if sleep doesn't have an absolutely vital function, it's the biggest mistake evolution ever made, right? Well, evolution doesn't make mistakes. One of the greatest biological mysteries of our times in the past, and great minds struggle with this. Francis Crick, who developed the composition of the helix and DNA, and Freud and his weird things. But the guy I admire most is Quintilian, a good old Roman like Santucci, right? And way back then in the 400s, he found the relationship of sleep to learning and memory. Sleep to learning and memory. And that's what we're finding out now. One fantastic book, which is easy reading and good background for you and the whole staff, is Why We Sleep by Matthew Walker. Why We Sleep by Matthew Walker. And it's a great book. If you're talking to your patients, this is some real good background information, both for the dentist, for the hygienist, and also the front desk people. But evolution doesn't make a mistake. So every 24 hours, two things happen. Number one, it nurtures the brain. It nurtures the brain. We get this while we're sleeping, this influx of cerebrospinal fluid that cleanses the brain, takes out all the bad stuff we built out during the day and brings in good stuff. It's almost like you're exercising and you build up lactic acid in those muscles, and the next day you kind of relax a little bit because you want that taken out and you want your nutrients to come in. That's what sleep does to the brain. It helps us to memorize facts. What it does, it takes our short-term memory and converts it into long-term memory. I'll have students come up and they'll say, oh, Dr. San, I think I did real well in your exam. I was up all night cramming for it, but I think I did well. And I said, well, congratulations. But if I gave you the same exam a week, 10 days, 2 weeks from now, would you do as well? And they said, I don't think so. That's right, because you haven't had time to convert short-term into long-term memory. And that's what sleep does for us. The other thing is that people who don't sleep well are a little bit edgy. It has an emotional effect on you if you're not sleeping well. So, the big thing here, it nurtures the brain. It helps us memorize facts, moves on to the next day. It also takes care of us, nurtures the body, helps our immune system fight off malignancies. We'll talk about the problem with insulin and floating glucose. How does it control our appetite, gut bacteria? And one of the biggest things here is the effect on our cardiovascular system. The cardiovascular system, which takes a beating when we are apneic or doing a heavy snoring and we're not getting a lot of oxygenation of the brain. And we'll get into that. So sleep supports normal production of stem cells, which are the building blocks for all our immune diseases. So good sleep reduces the body's inflammatory burden in the muscles, in the joints, in the blood vessels themselves. And this is a study on that, how cutting back on sleep changes the immune system itself. So you can see it's going total body. It's affecting our whole body, just about every organ system in the body. And you can have a role in that just by being able to refer these people. So what sets up our clock? How do we sleep? Well, we get the light coming through the eyes, it goes to the suprachiasmatic nucleus, and that starts setting up our behavior because that goes to the hippocampus. And I'm sorry we're getting a little bit deep here, but the hippocampus consolidates the process by which this information is stored. It's called the seahorse, because it looks almost like the seahorse. And if you're deprived sleep, again, the hippocampus doesn't have the ability to consolidate a lot of your memory or a lot of the things you practice. And it's even in training. Let's say you're training and you have a golf pro teaching you something, right? If you're not getting sleep, those lessons aren't maintained. That information isn't maintained as long as it should. You don't carry that to the golf course if you're deprived sleep. Now, this for me, even though I get enough sleep, I use this as a big excuse on why I'm a terrible golfer. But again, this consolidates all our training, our learning, and consists of the synaptic consolidation of what we're trying to learn and maintain. So there are two things that go on that are fighting one another. One is called orexin, and that says, I want you to stay awake, I want you to stay awake. And then adenosine, which says, I want you to sleep, I want you to sleep. And adenosine, which says, I want you to sleep, those same receptor sites are blocked by caffeine. So if you're taking your coffee and taking your coffee and taking your coffee, the adenosine is saying, I can't get in there, so I can't make you feel tired and want to go to sleep. And some of the orexin receptor antagonists are the things that we see in most of our sleep medicines. They stop orexin. So these two peptides are fighting each other all the time, a lot depending upon what we're taking internally and a lot depending upon how we're acting. It all comes down to what we call circadian rhythm in humans. Circadian rhythm is this kind of this internal clock we have. And you can see that on here, if you can read it. Melatonin, which starts the sleep process, normally starts at about 9 o'clock. But it all depends on light. And then about 2 o'clock or so, we're in our deepest sleep, and you can read when the body temperature changes. And then about 7:30, the secretion stops and we start our day. Now, this happens as long as we're not affected by other things which throw off the secretion of melatonin. And especially in like teenagers, they'll go upstairs, hey, mom, I'm going to bed, it's 10 o'clock. And they've got the blue light from their computer, their phone, et cetera, et cetera, et cetera. By the time they do fall asleep, it's 12:30, 1 o'clock. They have to get up 6:30 for a 7:30 class. These kids aren't sleeping. So in a lot of school districts, They've changed the start time from 7:30 to 8:30, knowing that extra hour has done wonderful things for kids, increased their ability to stay awake. You don't have all the accidents driving to school, help their participation in class, even improve their SAT scores. So this is state by state and local community by community that's adopting the change of the start time for children, especially teenagers, as they're going through this cycle change. So this is a normal sleep cycle. And you'll see step 1, 2, 3, 4. In some studies, 3 and 4 are combined. And then you go to step 5, which is REM, which is our rapid eye movement, which is the time that we do our dreaming. So it is important that you go through 4 to 6 of these complete cycles per night, uninterrupted. And that's the main thing. You may be in bed, say, I've been in bed for 7 hours. I've been asleep for 7 hours and I wake up. Why am I tired? Well, you may be tired because you haven't completed these cycles. For example, let's say you go from step 1 to step 2. You're starting to really fall asleep. You're starting to settle in, and all of a sudden, oh, I got to go to the bathroom. So you get up and you go to the bathroom, you come back. Well, you don't start where you left off at step 2. You go back to step 1. And let's say you go 2, 3, you're in step 4, you're really deep into sleep. An hour later, you got to go to the bathroom, off to the bathroom, you come back again. You were at 4, but now you go back to 1. So it's either getting up, going to the bathroom, or if you have young children, waking up with that, you hear strange noises in the house, some body parts are hurting, et cetera, et cetera, et cetera. You have to go through these complete cycles 4 to 6 times a night in order to wake up and feeling refreshed. Now, this is what the sleep study looks like. And you can see that you go stage 1, 2, 3, 4, then up to REM, which is our dream stage. And you go through at least 4 to 6 of these a night. And you can see earlier in the morning, the REM cycles or the dream cycles are starting to get closer and closer together. And it always fails that, your best dream is just before you wake up, right? And, oh, God, why did I wake up? It was the best dream I was having. And that's because these cycles are closer together. So we've given our patient the little form. They go to their primary care and they have a sleep study done. You need to have a sleep study authenticated by a sleep doctor. You need a diagnosis. You need a diagnosis on how severe is the sleep problem. Should it be treated? Should it be not treated? If it is to be treated, many times the physician will recommend a CPAP machine, which is highly effective, but compliance is only about 30 to 35%. People just don't like these things on their face. If they can't tolerate that, then they sign a waiver, and that's where we'll talk about MAD or mandibular advancement appliances is what we as dentists make for them. But you need a diagnosis. You cannot start treating unless you have a diagnosis. Breathing isn't optional, so we have to do everything we possibly can to keep breathing. But this is an extremely important slide. What happens when we're lying back and the genioglossus muscle and the mandible slide back? It closes off the airway and we stop breathing, apneic for that period of time. So a message goes to the brain and says, hey guys, my oxygen saturation is dropping. I don't want you to die. So the brain sends a message down to the trigeminal nerve, to the masseter muscle, having you stop clenching and grinding. You wake up and then you take a big deep breath. This is rhythmic masturbatory muscle activity, RMMAs. This is generated by the brain sending a message down. The brain also says to the heart, hey, you better go start beating faster. You better go into tachycardia. I need to get more oxygen up here. At the same time, all of this is going on, and you start, if you're holding your breath, you start building up what we call negative thoracic pressure. That pushes up on your diaphragm, which pushes up on the base of your tummy, and now you have GERDs, or you have acid coming into the mouth. So this, as I said, is a critical side, and sometimes you have to understand that you could have a blockage in the airway, or the blockage could be in the nose. You have to understand that it could be either or both. If it's in the nose due to polyps or due to allergies, deviated septum, that has to be taken into consideration. But the ringleader here is the brain saying, I need more oxygen. and it does everything it possibly can to wake you up so you can take a breath. And part of that is clenching and grinding. You take a big deep breath, and then you're excited because you're in fight or flight, and now the vagus nerve comes in, has to kind of calm you back down again. So I said the biggest effect on a lot of this is the cardiovascular system. What if you go into these episodes 10, 15, 20, 30, 50 times an hour? Your heart is in fight or flight, fight or flight, fight or flight. No wonder it's a big, big effect on this system. So understanding this and how we can help alleviate some of this, I think is really, really critical. Lack of sleep, these are some of the things that, come into play. It affects your appetite. You want to eat, you become irritable, your concentration worsens, your immune system cuts down. All of these things kind of come into play just by a lack of sleep. And I told you this about the fatigue and falling asleep at the wheel. Now, insomnia is something totally different. Insomnia is, you are in a situation where you should fall asleep. There's no reason why you shouldn't fall asleep. You don't have bright lights, you don't have noises, it's not too cold, it's not too hot, it's perfect, but you can't fall asleep. This has to be treated by physicians that deal with insomnia. It can be from depression, anxiety, illnesses, like so many different things, and it takes like medication to help a patient get through this. So this is beyond our study. The other thing that's getting more exciting in a way is there may be an association between a lack of sleep and Alzheimer's, pre-Alzheimer's, as people start getting a little older. One sign, this is a big study done at the University of California, that if you are sleeping or taking a nap of an hour or more per day, that may be an early sign of early Alzheimer's coming into play. Now, I must admit, right at lunch, I will take like a 15-minute cat nap. I wake up, I'm super. But longer naps, an hour, 2-hour naps, may be a sign of this early dementia setting in. How many people like the snooze button on their phone, on their clock rather, okay? Look at the percentages. 58% of Americans use it, UK 64%. So let's stop and think what's happening. So you set the snooze button for what, another 5 minutes, right? And then it goes out, you hit it again, and another 5 minutes, you hit it again. So let's say you hit it, 3 or 4 times. So during that period of time, you say, okay, I'm in bed an extra 20 minutes. But was that really good sleep? I mean, those 5-minute jolts, is that sleep? No, you don't get into any sleep whatsoever. So my thought was, instead of going through this rigmarole, and you're gonna, instead of 6 o'clock, you're gonna get up at 6:30, why not just put 6:30 to begin with, so you don't have this interrupted sleep? But then, people say, well, I hit the first one, it wakes me up a little bit. I hit the second one, it wakes me up a little bit. Okay, if that's what you want to do, but just don't think that it really adds to the quality of your sleep. It just kind of gets you started in the morning. Interesting. In Hong Kong, people close together, people, small rooms, small apartments, many of them not air conditioning. This gentleman, Kenneth Kong, saw that a lot of people were sleeping, on a bus or on the train. So he decided and say, hey, why not start a business where people can just come on and just go to sleep? And so he had these sleep buses, and people will get on here, and it's a 5-hour tour, goes about 50 miles, and people come on with their pillows and everything else, and they just fall asleep, which is fantastic. And nobody makes fun, because that's why you're on the bus. You're on the bus to sleep for these 5 hours. So it started with 1, 2, I think it's up to about 5 or 6 buses, and they're air conditioned, they're quiet, and people are getting their sleep. And sometimes they may do it a couple of times a week. But anyway, this is in Hong Kong. If you go and you have your sleep study done at a hospital or a sleep center, you have all these leads put on you, and all these information is gotten from all these leads. But again, you have to go to a facility. You're sleeping in a strange bed. A lot of people just don't like this. What's becoming more popular are the take-home versions, where you can actually sleep in your own bed. These are getting more popular, but they're also becoming more efficient. But still, whatever information you pick up here goes onto the cloud to a sleep physician who analyzes that material, and then you get a record or a diagnosis of your sleep or your lack of sleep, or what the irritable sleep and your oxygen concentration, how bad you're really getting. So these are becoming more and more popular. This is what the CPAP looks like. You've seen this on people. they feel I'm very claustrophobic. I can't stand this on my head. There are tubes and everything else. It's just not sexy, right? But anyway, it is what they call the standard of care. Efficiency is very, very high, but the compliance is only about 30-35%. So if you can't tolerate this, then the next step is going to our oral appliances. And there are about, I think, 140 different oral appliances, but they all do the same thing. It's an upper and lower appliance, and they keep your mandible forward as you lie back in your supine position or side to side. And they do this in various ways. Either they have little bands of different sizes or different strengths and lengths here, or they have a little screw device which makes the mandible come forward. This is the prosomnus, where you change the upper and lower trays to bring the mandible forward. Now, the efficiency on this is getting up pretty close to your CPAP, but the compliance is way, way up, like an 80-85%. So that's why many, many people are going to these mandibular advancement appliances other than trying to tolerate and living with a CPAP. Airway metrics, this is one of the things where I use. Kettenbach is a great company. They have orometrics. Like when we take a bite registration for a sleep appliance, it's different than you would for a night guard or anything else. So they have one system that I like to use. And then their Futar bite is a very strong biting material. I love it for both crown and bridge and mounting these cases. It cuts very well. And Catapult is, and I talk about them because I love their company. They just work directly with you. There's no middleman. And so it's kind of a secret that not too many people know about. They have fantastic product. In fact, they make a lot of the impression materials under a different brand. But it's something you may want to check to see. They can save you some bucks. Another technique, this is lasering the back of the throat. And it's a series of 3 or 4 visits. There's no anesthesia. They use a laser to hit the tonsil pillars, the back of the throat, the uvula, before and then after. And then many times people who have maybe a minor sleep problem don't have to have a CPAP or a mandibular appliance. They may be able to get away with this and maybe done every year or two in case the tissue comes back a little bit. So it's just a matter of affecting the collagen. The collagen kind of tightens up. As I said, this is done without anesthesia, and it's just got a tingling sensation more than anything else. Hypoglossal nerve stimulator is another treatment modality, and here you have a sensor that's placed underneath the skin. There is a lead that goes up to the hypoglossal nerve under your tongue, and what happens is that when your oxygen saturation drops to a certain amount, this sensor goes off. And when the sensor goes off, it affects the hypoglossal nerve, and then the tongue comes forward, and then in that process, you take a breath. And so some people say, hey, I don't want to deal with things, I don't want a splint, I don't want a CPAP machine, I want to try this. It's recently approved. This slide's maybe a year or two old. But it's kind of costly, like $40,000, and I'm not sure if insurances help pay. But this is called hypoglossal nerve stimulator. It's another modality of treatment. And then over the years, we had things to make us relax and fall asleep. We had lava lamps way back, and then we had mood rings. One of the newer things is what we call an aura ring. And as you're wearing that, it gives you some of your signs and symptoms of heart rate and other things. And one of the newer things out, one of the Apple Watches, you can get many different apps on it, and they're getting pretty good at picking up how you're sleeping, when you're sleeping, arrhythmias, et cetera, et cetera. So more and more and more, it's daily accountability on how we're doing, how we're sleeping, and how our body is responding to that. This is something new on the market. They said, the tongue muscles are lax. When you lie back, it slides back easily. They have this Excite OSA, and what it does, it stimulates your tongue, and there's like exercises for your tongue to make your tongue stronger, and so you don't get this floppy tongue going back in the oropharyngeal region. Some people are mouth breathers, even with or without these appliances. So you have these strips. You have that one on the left that has a little hole in it. This one from Japan is an X. And this little girl, she's sleeping well, but she just wouldn't stop talking, so they taped her up. No, I'm just joking. Something about countries. I can't see on top of my slide. It's called inuri in Japan. It's the inuri. The practice of being present while asleep is common and viewed as a sign of a hard worker. And so, people sleeping like this, they assume they've worked real hard. They are present, they are probably listening, but they say they're also sleeping. I get this a lot from my students, and I tell them, sorry, I'm not going to buy this. But anyway, in Japan, inamuri is this state of present while sleeping. I think that little kid's adorable. POWs. I had the opportunity of treating some POWs when they came back from the last war. And, these poor guys went through so much. And I was asking them how it was. And they said, the beatings were bad, but the worst part was they interrupted my sleep where I couldn't go into my dream stage. And they would watch it when you go into rapid eye movement into the dream phase, your eyelashes or your things kind of flutter a little bit so they know you're starting that, and they would wake them up. And not being able to dream had more of a deleterious effect on our morale than actually the beatings. And so way back, they were smart enough to know that this is something that they can break people down with, which was kind of sad. So that's a little bit on the sleep background. So what is the synergistic interplay between dental sleep medicine? How does what's going on in sleep medicine affect our general dentistry? And that's the direction we're going. This is a great article done by Jeff Rouse, but this was in 2010. And he said in a lot of his patients, he's been seeing a real close relationship between patients with Gerds and sleep bruxism and sleep apnea. And the Gerd setting out the sleep apnea causing Gerd, sleep apnea, they have sleep bruxism, round and round and round and round. And my friend and I looked at it and we said, we also think that there's a saliva involved, erosive tooth wear, and also some periodontal effects and TMD effects. So this triangle, way back in 2010, they were starting to look at the interaction of all these functions, and both on the medical and on the dental side. And some of these we can actually pick up in our office ourselves. During the TMJ exam, what things seems to set up as we're doing our exam. If you have a patient that says, hey, I'm waking up a lot with pain on the temples, and these muscles down here in my jaw are real sore. So I will palpate those muscles and I'll have the patient clench. And if those muscles get really hypertrophied, I'll have the patient bring their hands up and feel them themselves. You say, these muscles are exceptionally large. And a lot of this is because you're clenching while you're sleeping and grinding your teeth. And so we'll talk about either a sleep concern, or maybe it is just going in there with a night guard of sorts. But this is one way of picking this up. This is a little video.
The temporal mandibular joint
on yourself,
the TMJ,
and it goes through
the natural between the
natural moving of the jaw. And you can pick it up when you review this again when it's recorded. But the main part is that TMD, a lot of it can come from micro trauma. It could be macro trauma, you get hit in the mouth, but micro trauma from clenching. And if you're clenching and grinding your teeth in your sleep, your jaw is usually forward. And now you're clenching in that forward position. Over a period of time, you get a stretching of the ligaments, you get a loose disc, and now you start getting clicking and popping of the joint. So there could be this relationship of initiating TMD problems from a sleep etiology, and then you have to consider both of these concerns. Comorbidities from sleep, there's so many of them: headaches, mostly temporalis headaches, pain in the jaw, the neck, cravings. We'll talk about food cravings. We'll talk about obesity, cardiovascular disease, focusing, which we talked about, sleeplessness, and waking up feeling refreshed. This on the upper right side is a little poster. It's from C2 Sleep Solutions. And this is a great poster to have in your hygiene room. Hygienists, they're the backbone of our dental practice. The patient comes in, they do the little sleep survey at the desk, that stop bang or one of the others. Then they come in for their hygiene appointment. They say, oh my God, Susie or Jane, what's that? That's a new poster. Yeah, you did the sleep survey and you scored a little high. These are some of the things that may be affecting you. And it starts a conversation with the patient. And, as you're cleaning and do your probing and everything else, instead of talking about, what movie star is being divorced, who's sleeping with whose wife, you may want to talk about something that has the total effect on their health. And so they're very, very appreciative. If you look at the left and you look at the diseases that are associated with obstructive sleep apnea, from hypertension to diabetes, obesity, the bottom is the scariest one: nighttime heart attacks. The biggest incident of nighttime heart attacks is in young men who either have undiagnosed or untreated obstructive sleep apnea. And this could be young men. And so that's kind of scary. 91% of these people may be in line for that. That's a scary statistic. But anyway, between the little poster and some of this information, sometimes you can get your patients' interest. So what happens to the immune system? Well, in the immune system, the more you sleep, if you sleep well, it helps to fight off infection. When you're ill, you want to sleep. And there's a study that said in 2002, the effect of the flu vaccine was less if you weren't sleeping well. And I was just wondering, we're not sure what actually the COVID vaccines were doing or are doing or will be doing, but maybe inappropriate sleep makes them less effective. Cancer, there are killer cells that attack these malignant tumors, the activated T cells, and the amount of them and the activity of them really determines how well they fight off tumors. And a lot of this depends upon your sleep. Here's a study done in Denmark, and they said these shift workers, where they're on nights and they're on days and back and forth, increased odds of breast, prostate, and colon cancer related to this disturbed sleep pattern week after week after week. So this is really critical. I mean, when you start dealing with cancer, you're dealing with these activated T cells, and the majority of them are more active and are more effective when you have slept well. How about obesity? There's multiple arousals while you're sleeping affect the endocrine system, and certain hormones are affected and are out of balance if you're not sleeping well. And the bad hormone that comes up when you're not sleeping well is called ghrelin. And ghrelin says, you're hungry, you're hungry, you're hungry, you're hungry, keep eating, I can't wait to get up in the morning, I have to go down to breakfast. You're never satisfied. You have that sense of saying, hey, I enjoy having that half a loaf of bread before the meal comes at the restaurant, right? It has you going in the wrong direction. The good one is leptin, and leptin is there when you're sleeping well. And leptin suppresses your appetite, promotes weight loss, and it says, you've had enough to eat. You don't even need the bread before your meal comes. And if these two are out of balance, you may be doing everything you possibly can. You think you're watching your diet, you're exercising, you're taking some medications, but if you're not sleeping well, the bottom line may be that it's because these two, leptin and ghrelin, are out of sync. We're all hungry at bedtime, right? You want, what should I eat? I want it sitting in my stomach at night. These are a couple of things that they recommend. Kiwi, pumpkin seeds, and cheese seem to be something that you can nibble on before you go to bed, just to kind of cut down on that desire to eat something just before you go to bed. What's happening to Generation X? Now I have this up there because if you see the guy on the right, you say, well, this guy has a sleep problem, he has no neck. I'm sure when he lays back, he doesn't breathe at all. But look at this little guy on the left, little pencil neck there, saying, hey, he shouldn't have a problem at all. But yet we're finding that a lot of these people, like models with these long, beautiful necks and stuff, this neck is just a long tube. And if you're sleeping and it's bent, you're not getting the oxygenation you need. Or it could be in the nose. There could be some polyps or a deviated septum or whatever. So anymore, we just can't look at someone and say, boy, that guy has a sleep problem and this other person does not. Here's a study done by Evan Cotter, and she had these people sleeping 8 to 9 hours a day, and they ate in this cafeteria, and everything was marked on what they ate and the caloric intake. And then they had to come back 2 or 3 weeks later, and they changed, instead of 8 to 9 hours, they would let them sleep 4 to 5 hours. And they find that when they slept less, they increased 300 calories more a day. Well, 300 calories a day is not that much, right? But when you look at, it's only about, what's that, 2/5 of a Ruby Tuesday veggie burger. It's not a lot. But, when you're sleeping less, 300 calories a day, that's 70,000 calories a year. And that's where I think your 10 to 15 pounds of fat is. So if you ever want to look in the mirror and say, hey, what does that 10 to 15 pounds of fat look like? That's it. And maybe this is a picture we should put on our refrigerator and say, I don't think I want that extra cheeseburger now or whatever. I keep seeing that ugly 15 pounds of fat just hanging there. So what happens with the genes? These spiral strands of DNA are floating in your cell nucleus. And with disturbed sleep, what is affected is what we call the telomeres. These telomeres are at the end of the strands. And the telomeres, I think the best way to explain it is like the little plastic applet at the end of your shoelace. that keeps the shoelace from unraveling. Well, the telomeres do that to the strand. And once you get older or you're ill or you're not sleeping well, these telomeres start breaking off. Well, what happens is that the cell is no longer reproducing. What happens is we see aging, we see changes in the skin, we see changes in everything that the aging process comes into play. And it's because these telomeres are not as effective in keeping the cells together, the DNA together, so they are not reproducing. And that comes on with aging. So if we sleep well, there is a tendency for these telomeres to hang on much longer and making us look fantastic through the age of 90 or beyond. How about the reproductive system? In men, I'm sorry, that's overlaid a little bit, but if you're not sleeping well, 29% have a lower sperm count with increased deformities in the type of sperm, a decrease in testicular size and testosterone, the guy just isn't as potent as he thinks he is, but the ladies, you guys don't get away with it either. If you're not sleeping, there's a 20% drop in follicular releasing hormone required for conception. Now, where I practice here, right in the heart of startups, husband and wife many times work at the same startup or similar startups. Well, they're getting maybe 4 hours of sleep a night. They're just married, they want to have kids. They're spending thousands and thousands on IVF. Has anyone ever talked to them about, are you guys sleeping? If you're sleeping 4 hours a night, both male and female are not being as reproductively productive as they should. So maybe instead of saving them some bucks and saying, hey, you scored pretty high in this little survey, this may be what's causing an interruption with your being able to procreate children. Diabetes. Remember we said hormonally, leptin and ghrelin are out of kilter? Well, there's only so much extra sugar in the blood that the insulin can handle. And with not sleeping well, you get an overload, you get a decreased sleep, cell sensitivity to insulin decreases, and you start sliding into a diabetic stage. Or if you are diabetic and you're taking medications, you're watching your diet, you're exercising, but you're still not getting your numbers down, one reason may be that you're not sleeping and your sensitivity to insulin is decreasing. So what does all this mean in our practice? Okay, this is fun, it's good stuff to hear, but let's get practical, right? How does all this evaluation, fit into your practice mode? What does the ADA really want us to do? Well, basically, just have a little sleep survey and refer, if they score high, to their primary care, or if you feel over a period of time you actually want to get involved with treating patients, then we highly recommend you take a mini residency in sleep. We have one at the University of the Pacific. It's run by myself and Jameson Spencer. He is well known throughout the sleep industry for years. Tufts has one, UCLA, they're springing up all over, but that gives you about 65 hours of time that you need learning not only about this, but how do we build, because appliances are billed through their medical insurance, which is totally different than their dental insurance. So there's a lot to learn, but more and more people are doing that. Now, on my side, one of the things that's helping me is I've cut my general practice back dramatically. And because of that, I've had pain in my shoulders and stuff like that. And doing long cases, I used to do a lot of full mouth rehabilitation. I just don't do that anymore. I can't sit down at the chair for 3 or 4 hours and not moving. And so with sleep, my system takes impressions, I evaluate that, I'll take the bite registration, the appliance comes, we deliver the appliance, we titrate it, and it's a lot easier on me personally. But some people who are, doing this for 30 years or so, and they're getting less and less like they just want to do general dentistry, this may be some way of filtering off. You're kind of partially doing dentistry, but you're not doing the sit-down dentistry that is really destructive to all parts of our body. So when we're looking at the patient and we do our normal exam, we're going to look at the teeth, we're going to look at the gingival tissue, we're going to probe, but maybe if we stretch this just a little bit. Is there airway crowding? Are the tonsils touching one another? We'll show you that. Is there a high narrow palate? A restrictive lingual frenum? And I'll mention that later. Malapati index, I'll show you that, a scallop tongue. And if some of these things are coming up and they score fairly high on their survey, you may just want to bring up the idea again that say, what you started on the survey, I'm seeing some of these things going in your mouth. I really, really recommend you take the survey and bring it to your primary care physician. Or once you get a sleep study done, dentists who do treat these types of individuals will be happy to see us. But this is some of the things you're looking for. So primarily are tonsils, and these are kissing tonsils. These are type 4. The biggest way, both in adults and children, to improve sleep and to improve breathing is just to have the tonsils removed. I know there was time ago where they stopped doing children. A lot of this 1 or 2% have this irreducible rate of post-op hemorrhage. 1 or 2 children died, so everybody kind of looks scary about it. But now technique and everything else is getting much, much better. Sometimes they're doing a partial resection of the tonsils, but really this is one of the main things to look for. The other things, secondary findings, are they mouth breathers? Is there nasal airway obstruction? Allergic shiners, they're like the little blue or purplish lines underneath the eyes. And you see this a lot in children, especially with allergies. Is there Gerds involved? Excessive tooth wear, which we'll get into. High vaulted palate, where there isn't room for the tongue, and a long adenoidal face shape. And this goes along with some of these kids have allergies. Now, this is the Malapati Index, 1 through 4. It was started by Dr. Malapati, who's an anesthesiologist, and he found that in the morning, some people are just more difficult to intubate than others. So he started looking at them the night before, and he found everywhere from class 1 to class 4. You start looking at a class 3, you have the patient stick their tongue out, and if you can hardly see anything going on back there, more than likely when they lay back and the genioglossus muscle relaxes and the mandible comes back, you're going to go pretty much into a class 4, which says everything is blocked off. So either you're going to do a lot of heavy snoring, or you're going to become apneic. And if you have nasal congestion, you really have a lot of trouble breathing and keeping the oxygen saturation to the level it's supposed to be. How about a scalloped tongue? We see this all the time. What do you tell your patients? Mrs. Jones, you have a scalloped tongue. Oh my God, what is it? What is the etiology of a scalloped tongue? Well, it can be Down syndrome in children. They have an extra large tongue. Hypothyroid disease. I'm seeing more and more women with hypothyroid disease. And I don't know, maybe we're more sensitive to it than before, but I'm seeing this more and more. Apert syndrome, that's where the brachial cleft 1 and 2 didn't develop properly. Amyloidosis is protein deposits in all parts of the body, especially the tongue, and the tongue gets larger. But probably the 2 biggest things is sleep apnea and parafunctional activity. And I mentioned in sleep apnea where you got that RMMA, where the brain sends down a message to start clenching and grinding. And then parafunctional activity, we know many times that's anxiety, and we'll get into that with Bruxing a little later on. But these are some of the etiology of a scalloped tongue. And again, this is the old triangle again from Jeff Rouse. Children, I don't have a lot of time to spend on children. Sometimes this is an hour by itself. But 25% of some form of sleep disorder we find in our kids. Snoring, occasional, habitual, some obstructive sleep apnea, some are just poor sleepers. What's the bottom line? Hey, mom, come on in. Little Johnny is snoring and grinding his teeth. Isn't it cute? He's like 2 or 3 years old. Say 3 or 4 years old, they have teeth, right? Parents, doctors, hygienists, staff, listen to me. Children who snore and grind their teeth, it's not cute. It's not cute. It affects the prefrontal cortex of the brain. You don't get oxygenation of the brain. The prefrontal cortex is the gray matter. The gray matter determines your ability to make decisions, and it makes you not ADHD. It also has to do with your IQ. So it's very critical that toddlers, the young kids, doing this, please have them at least seen by the orthodontist. If they have a palate that's constricted, they're not sleeping well, but just don't say it's something cute and they're going to grow out of it. As they're growing out of it, what is happening to the child's brain and development of the brain? So just throw this out. This is so easy to do. This is a great book by Sharon Moore on sleep-wrecked kids. It goes into a lot more detail on what's going on with these kids. This is a survey you can pull down for children. If you have a lot of children in your practice, this is called the Bear Sleep Screening Tool. And there are questions that are appropriate for the child and the parent at different ages. So this is something that's used quite effectively. Restricted tongue. If either the adult or the child has restricted lingual frenum, what happens is that as they swallow, the tongue can't go to the roof of the mouth. And because of that, the as the child is developing, the buccinator muscles are pushing in, and usually when you swallow, the tongue goes up, hits the roof of the mouth, and it neutralizes the effect of the buccinator muscles. If the lingual frenum can't get the tongue up there, the palate now becomes a high vaulted palate. In Brazil, at birth, if they think there's a restricted frenum, they just snip it at birth. So this is something that they feel very strongly about. Orthodontics, man, expanding those arches in kids and in adults is just first stage. Without a doubt, it's something very, very serious that can be taken care of. Mouth breathers, what's the big difference? Well, if you're breathing through your mouth, you get a lot of dryness of the oral cavity, the pharyngeal airway spaces. And there's a difference in the effectiveness of breathing through your nose and your mouth. You're not as effective in breathing through your mouth as you are through your nose. You don't get the nitrous oxides put into your breath that goes and gets the oxygen into the cells much sooner. So mouth breathers aren't as effective as breathing through the nose. And these are some of the things we see with mouth breathers. Sleep bruxism, myths, conceptions. So is tooth wear related to bruxism? What is the cause of bruxism? Are all bruxisms alike, sleep and awake bruxism? And there's a splint therapy. What does the result in less bruxism? Hey, Mrs. Jones, I see you're grinding your teeth are wearing down. I'm going to wear this nightgown. Doctor, will this stop me from grinding my teeth? And the answer is no. You still have the habit, but what it may do is cut down the effect on the teeth. Teeth against teeth, we can generate up to 200 pounds a square inch of pressure. When you're biting down on a piece of plastic, you get maybe 30 to 40. So the effect on the muscles and everything else is less, but the habit still persists. Great book again. This is by a friend of mine, Gilles Levine. Everything you wanted to know about bruxing. So wear is not a good indicator of whether you're bruxing or how much you're bruxing. Self-reports are not liable. You ask a patient, they did studies, do you clench and grind your teeth? The answer is no, and then the studies are done, you do. And someone says, oh yeah, I do a lot, and studies that show that they didn't. And so the only way is to do the EMG as a gold standard, but we're not going to do that all the time. But the main thing is asking the patient a rhetorical question. It's almost like, you don't get a reasonable answer back. So don't rely on that. But this shows that here we have a sleep study going on. There's a time here where there's obstruction. The muscles are doing great, 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 great. Then right after the obstruction, what happens is that you see a huge burst in the EMG reading of the muscles. This is at that time when the brain is saying, hey, clench and grind your teeth, open your mouth, take a breath, let's move forward. So this is real good advice on that relationship between obstructive sleep apnea and clenching and grinding. When you look at these episodic natures, when you're looking at this, you can say maybe on the occlusal surfaces here we have wear, but you don't function back here. Something else is going on back here. And this is what's really critical to understand. Sleep bruxism and awake bruxism are two different things. Sleep bruxism, you can't control. It has to do, it's centrally related to your sleep cycle. It's your brain telling your jaw to start clenching and grinding, whereas daily bruxism during the day is under peripheral control. You can stop it if you want to. You just start to understand what habits are you doing that's bringing around this type of interaction. So there is a difference between sleep bruxism and awake bruxism. I'm sorry, but we used to think years ago that people bruxed their teeth because of occlusion. And those of us who did full mouth reconstruction, we put all this fantastic work. And then at the very end, we say, oh, Mrs. Jones, here's a night guard I want you to wear. Well, if we did this perfect occlusal relationship and disclusion and this and that, why in the name of God do they need a night guard? Again, occlusion is important. Individual teeth, some teeth are sensitive, some are being hacked away because all that is, yeah, I understand all that. But it's not the main reason for bruxism. And that's something that we had to get out of our minds over a period of years. And we make, the night guard, the occlusal appliance. The only scary part is I came across some studies, especially from Gilles Levine in Canada, saying that there's a pilot study that if people have a minor sleep problem and you make a traditional night guard, you may in fact be increasing the type of sleep problem that they have. And I got kind of nervous because I was looking back, and I think I've done between 4,000 and 5,000 night guards between my patients and the school. So now, you may do what you want, but to me, before I do a traditional night guard, we've done veneers or whatever, I also have them fill out that little sleep survey just to say, hey, is there a possible problem? And before I go in and develop and deliver a night guard per se, I want to make sure that at least for all we know, all we can tell, there is not a sleep problem there. And if there is, they should have that be evaluated first. Okay, it's break time. All right, break is over. Let's talk about wear and acid, which is very, very closely related to all of this. Is bruxism the main cause of wear in any of these cases? Now you're looking at some of these, and on the upper left, I mean, there's more cervical breakdown than there is anything else. The upper right, what kind of occlusion or what kind of bruxing problems or parafunctional habits cause that problem? And we'll see this later on. But let's look at these lower ones, left and right, and you can see where there's all this excessive wear. And yeah, parafunctional habits were involved, but is it the main cause of wear in any of these cases? You look at some of these, and maybe the lower right side, you can say, you know, maybe just parafunctional habits, but I don't think so. Something else is going on to cause this type of breakdown. And that's the critical thing that we have to start to understand. This is a new word, tribology, that I've found over the years, not over the last year or so, and it's in mechanics and stuff, but it's a science of two surfaces interacting together with the lubricant in between. Well, is that kind of what we do when we clench and grind our teeth and we have saliva or we have food in there? So I like this word tribology. When you have these surfaces moving together, wear is caused by the breaking away of enamel asperities. And here's something that shocked me. Assuming there is no acid in the oral, in the patient's mouth, no acid, either intrinsic or extrinsic, over 30 years, you should lose 1 millimeter. 1 millimeter over 30 years if there isn't an acid component. So what causes all this excessive wear? There's a chemical, there's a mechanical, and there's a behavioral component. The chemical is the softening of these tooth surfaces by dietary and intrinsic acids. Acid comes into the system. And then when we do start clenching and grinding our teeth, the effect is 27 times greater than if we did not have acid in the system. And then the behavioral part is, you know, is this something that we can check during the day? This is the daytime bruxism, and some of that we can cut down. But the critical part here is that there is a softening of the tooth surfaces that makes them more susceptible to our parafunctional habits, and that's the acid in our system. And so, you know, you're looking at these, there's natural wear, even these old ceramical crowns where they wear down teeth. This is years ago. And it could be just one factor, but most of the time there's also another factor, and that's acid. So what happens in the erosive process? Nothing happens on the tooth until it happens in the saliva. You know, the saliva, the quality of it affects the acquired pellicle on the tooth surface. Well, you get acid in there, dentin starts breaking down when the pH goes down to 6.2, enamel down to 5.5. And the severity of this depends upon the pH of the acid that comes into the mouth, how much of a buffering capacity does your saliva have. When you're having drinks that have acid in them, how are they, do you sip them, keep them in your mouth? And is the saliva, is it able to buffer? Is it able to clear? Do you have enough saliva? And what's the thickness of the pellicle on the teeth? All of this kind of comes together and showing how much wear we actually see. Now, this is critical. What's the difference between caries and erosion? Well, caries involves bacteria. We know it can be reversible and all that, but caries cannot exist when the pH goes between 4.5. Why? Bacteria don't live there anymore. But erosion, on the other hand, there's no bacteria. This erosion comes from intrinsic and extrinsic acids on the surface. And this is more subject to wear, and in other areas, it's just bathing that area like these cervical regions. So there's a big difference between lesions we see from decay and big lesions that we see from erosive breakdown of acids. Now, intrinsic acids, acids that originate in the stomach, can be related to Gerd's, bulimia, anorexia, or several combinations. So what happens here? If you go into you're sleeping and you go into an apneic episode, you stop breathing, you build up this, what we call negative thoracic pressure. That pushes up on your diaphragm, which pushes up on the base of your stomach. and up comes through the sphincter. You start getting the acid up into the esophagus, up into your mouth, and even up into your sinuses. And this acid, the pH is 1.2. And this is strong enough to take the rust off a trailer hitch, right? So this is very, very corrosive acid that's coming up into your system. This increase of pressure, as I said, causes the negative pressure. Up comes the acid. It affects the teeth, the gums, the throat, and everything else. So there's a close relationship between obstructive sleep apnea and GERDs. Why do people live on Prilosec or Nexium or whatever? It's a way of life. Well, I've taken my Prevacid. I can eat whatever I want. Does the medical community, or even the druggers say, hey, you should only be on these things maybe 2 weeks at a time until you start changing your habits? No, because it's a $14 billion inventory that they sell every year. And this is a couple of years old. It's probably even more. So, they're fighting, the ads on television of fact, and the physicians say, here, let me write you a script instead of going into what's really causing the problem. And related to this may be the sleep problem. So that's intrinsic. How about extrinsic acids? Well, a lot of this comes from, look, fruit juices, soft drinks, etc. All these things that we drink throughout the day that has acid in it. Here's a study done where they had these drinks, Red Bull, Gatorade, Powerade, etc., and Coca-Cola, and they soaked extracted teeth into these acids for 2 weeks. And then they measured how much wear or how much erosion occurred on these, and they measured and they did certain other studies. Well, Red Bull was the worst. But hey, Coca-Cola is down there at the bottom of these 5 or 6 drinks. Why is there a difference? Well, there's a difference in the acid in the Red Bull than the acid in Coca-Cola. In Coca-Cola, we have phosphoric acid. It is not as strong as the acetic or malic acid in these other sports drinks. A friend of mine who owns a bar had, he said, I'm opening so many of these cans of Red Bull. He said, I'm cutting myself and everything else. We put it on draft, right? After about 2 months, he had to go and change all his lines because they all deteriorated. So I don't know what this is doing to your stomachs and everything else, but there is a very, very caustic acid that's happening here. The other sad thing we're seeing in our kids, hey, my sports hero drinks Gatorade or this or that and the other thing. And kids more than more, moms say, hey, there are all types of electrolytes in there and stuff. Let's give it to the kids. It's better than this and that. No, it isn't. We're seeing a lot of this premature breakdown on children from the acids that's coming into the mouth, especially if they're kept in the mouth for long periods of time. Sometimes when I'm on the road, I have some fun and I'll have a little container with about 10 of these little sugar cubes. And I'll say, hey, anybody comes up and within 5 minutes, eats these 10 sugar cubes, I'll give you $100. And well, I don't want to do that, right? Then I hold up a bottle of Mountain Dew and I said, hey, anybody who drinks this Mountain Dew, I'll give you $100. Oh, everybody puts their hand up, right? I said, wait a minute, what's the difference? All these sugar cubes are in this thing of Mountain Dew. It's just a different method of transferring all the sugar and stuff, right? So you have to watch your colas. You have to read the labels, how much sugar is in there, what kind of acid is in there. And a lot of things need behavioral modification. So how do we look at this dental wear and how can we affect this acid disease? We're looking at control, how much acid hits the teeth, protecting the teeth from acid by certain types of items I'll get into, and minimizing these frictional forces. Thus, it involves more than just bruxism. The bottom line is excessive wear with the parafunctional habits needs a softening, and that's done by acids, really intrinsic or extrinsic. Here's the difference between fluorides. Stannous fluoride on the one side, sodium fluoride in the middle, and a control. Sodium fluoride almost just desensitizes the tubules, whereas stannous fluoride actually blocks the tubules. There's a difference in their mode of operation. And the other thing is the saliva. How is the saliva working? Do you have a buffering capacity in your saliva? What effect is that having on the pedicle of your teeth? Now, the saliva affects the acquired pedicle, which attacks the tooth surface. And as we get a decrease in pH, we know that, as we said before, it affects the dentin and the enamel 6.2 and 5.5. But what about adenophysis? And what causes these NCCLs, these cervical non-carious lesions? When I went to school, Grippo said, hey, in your parafunctional habits, especially in your excursions, you're putting a torque on the tooth. There's a little bit of flexing that occurs at the neck of the tooth, and we kick out these little enamel asperities, and that's why you have these little grooves. Abramson did some studies, and he said, hey, I can duplicate that in the lab. It's not so much in different types of toothbrushes, but it is the type of dentifrice that we're using. And if the relative values of the dentifrice, you can look up every one in the ADA journal, And if it goes above 250, it's becoming more abrasive than it should be. But when Abramson did his studies, he doesn't have the saliva in there, he doesn't have the other things. So I still see, most of the time when I see abfractions, I'll look at excursions, and sometimes I see these little cracks coming down, or I know excursions are hitting in excursive movements. And so I kind of tend to see, I'm still a little bit on the occlusion side. So stannous fluoride, as I said, it blocks out the tubules more than sodium fluoride does. And here's a study done with the Crest Pro Health, which is a stannous fluoride, against some of the ones with the high 5,000 per unit sodium fluoride, like Sensodyne or the others. And the stannous fluoride, really, the surface enamel loss was much less. So my thought is, in these people where you have acid, where you see wear, excessive wear, acid is coming in somewhere. So both from the wear facility and also the stannous fluoride, this one is from Crest, I think, I forget the name, gingival inflammation and Pro Health. What they do is they really sit down in the crevice a lot longer. And I'm really partial to the Crest products just because of what they do with the stannous fluoride, both with the acid situation and also helping with the periodontal tissues. So what's sleep apnea and periodontal disease. I'm sorry we can't see the top of this here, but they're starting to show a relationship between sleep apnea and periodontal disease. You have there's this relationship of the interleukin and the pentraxin 7 levels in both patients with periodontal disease and sleep disturbances. Now, does one affect the other? There's another study done that when you have both sleep apnea and periodontal disease, it was in a higher prevalence of people that just had either sleep apnea or periodontal disease individually. So this is something periodontists we're seeing more and more and more. It's this evaluation of the same cytokines floating in the system, and one may be affecting the other. Now, MI paste is a GC product, as you know, and I like to, people that have periodontal problems, I like to use the stannous fluoride, and then at night before they go to bed, rub the MI paste on their gums. Just spit it out and just leave it on all night. To me, that's a real good, effective combination of medications or things that they can use to cut down their periodontal disease. And then you bring in mouth breathers and everything else. The more you can help the environment and coating the teeth and making the periodontium stronger, I think the better off you are. And this is, what periodontists should know. More and more studies are coming out on this, as I said, and it's this cascade of these inflammatory responses that seem to share them equally, both with perio and obstructive sleep apnea. Saliva buffer test, it's good. This is another GCA product, and it's a little kit. Then you buy a little box, and it comes with all these little things. And what's nice about this is you can do this buffer test right at the chair with the patient. And they spit into this little thing, and you put a drop onto this little paste, and then you come up with a reading, and you can show the patient, how effective is their saliva in buffering the acids that come into their mouth. And this is better than showing them just a book or something else. This is their saliva, and this is what's happening at that time. So what's the concern? The biggest concern is baby boomers are starting to overtake the market more and more and more. You can see the difference between the red there is the baby boomers in 1960, 1980, they're moving up. Not only are they moving towards the top, but they're getting wider. More and more and more baby boomers are hanging around. We are living longer. And therefore, as we go into patients our 70s or 80s or 90s, we're seeing more and more patients with wear, and they're literally outliving their teeth. Now, when we see patients like this, who has failed? Is it that we have not picked up problems early enough? Or is it the patient didn't even care? I see a lot of these patients on the left, they come in and say, oh, Dr. Santucci, I don't like my smile. Well, actually, my wife doesn't like my smile. And I look at this and I'm thinking, what do I do? I mean, you have to open up the bite, do a full mouth reconstruction. It saddens me. Has anyone ever mentioned to you before that little by little by little, you were wearing things down so you don't need to have total rehabilitation? As I said before, teeth softened by acid can be 27 times more susceptible to abrasion than teeth that are not bathed in acid. And this is the effect that you see when both of those things come together. If you start thinking of this erosive wear as something that is part of their overall health, and you're looking at these things and you're saying, is there something other than the grinding and the wear that's causing this problem? And we look at it and we say, how can we deal with this? Or are we just going to observe and wait when they're very minor? Do we apply fluorides to some of these cervical areas? Do we use sealants, or do we restore? If we see these little cupped out lesions, this is erosion. This is not decay. Doctors, do you restore these? I do. And I build them out as occlusals or wherever they are. Because over a period of time, those little simple occlusal lesions are going to turn into this if you don't understand the etiology and start telling the patient what the etiology may be, take care of these lesions when they are minor so they don't get to this stage. And also, when you see some of this wear, it may be some signs that there's some other serious medical problems coming up, like Gerd's or bulimia, that I'll show you in a little bit. Here's a sad case. You're looking at this anterior wear. You're looking and say, well, that's not occlusion. I mean, what's going on here? Well, what's going on is there's a young girl in 2007 and then 2015. She had bulimia. No one had picked it up. Not only does she have bulimia, but now she's getting into, she has an anterior open bite, she has a tongue thrust problem, she has a severe ortho problem. Wouldn't it have been great in 2007 if someone came up and noticed some of this stuff and directed her maybe to have some type of intervention so that she wasn't set up with this. This is where it becomes important. Some of the products I like this GC varnish because when you put it on, it doesn't stain or it doesn't turn yellow. And on very, very minor refractive type lesions and stuff, I think the MI varnish is a great treatment for your patient. And they find that even putting flowables into some of these little micro lesions, that the flowable is still there over years, and it helps hold back the acid attack. The flowable I really like is by Shofu, and I mentioned the products that I use, and their Beautiful Flow Plus or Beautiful Flow X. I love it because it neutralizes the acid. Once it's in there, the acid in the mouth that comes around the restoration is neutralized by this. And you can read about or talk to your rep about Shofu rep on how this works. But the other thing I like about this is wherever you put the flowable, it sits there. It doesn't drip all over the place. And they have some great slides where they're just layering it on top of a little staple, a couple of staples together, and they just keep layering layer on top of layer and nothing breaks down. So this is a product that I like and I use a lot, and this is from Shofu. Other product that I love a lot is Ceramir, and that's Doxa, which is now Directa USA. Same product, same beautiful staff support. And what I like about this, when you cement a crown, it resists the acid and the acid-producing bacteria. The cement does that. What I also love about this, if you do cementable, there are certain times when you have implants and you can't screw them in, you've got to cement them because of access. This is very, very highly radio opaque. So you put you cement it in, you take your post-op radiograph, and you can see if you have excess cement in there. One main causes of periimplantitis is what? Having excess cement on these crowns that you've cemented. So a super product, whether you're doing it for implants or whether you're doing it for routine crowns, I highly, highly, highly recommend Ceramir because of this acid resistance, especially when you have your patients that have a high acid component to what they're dealing with. So the take-home lesson is what? Think in terms of tooth wear. It's not just bruxism. It's all these other things that come into play. And most of it has to do with acid. So here's a few objects for today that we've talked about. I'm sure we've gone through this and a lot of stuff, is very fast at you. But some of the thoughts, think of bruxism as a wear problem, not just tooth grinding. And I think we talked about that. We know the different types of bruxism, and we know that acid in there really affects this directly. If it's a wear problem, what is the cause of this tooth structure loss? Any of these things can come into play along with the acid. Bruxism, there's a difference between sleep bruxism and awake bruxism. Sleep bruxism is centrally mediated by your brain. You can't do anything about it. Daytime bruxism, it's an environmental problem. You can adjust it. You can deal with it. Again, it's under your control. Why are we making a night guard? Are we doing it for bruxing problems? Do we know it's just a bruxing problem? Do we know there's a possible sleep entity involved with it? We don't know. What is the role of saliva? Is the patient's aerostomic? Are they on a lot of meds? And at night, the output of saliva is only about 10% of what it is during the day. So when do you think the GERDs comes up? Well, they're laying back and they're asleep. So they're coming into an oral condition that has a decrease in saliva to deal with the increased acid coming in. Definitely a severe problem. And acid plays a huge role in everything. What's the difference between healthy sleep and disturbed sleep? It doesn't matter how many hours you're lying in bed. If you haven't gone through the cycles, 4 to 6 cycles completely, you're going to be fatigued. What are all these comorbidities? We talked about sleep, everything from cardiovascular disease to diabetes to reproductive problems, et cetera, et cetera. What is the importance of nasal breathing as opposed to breathing through your mouth? If you have congestion, you're not breathing, you're forced to breathe through your mouth, irritates the tonsils, you get inflammation and swelling. And then we got into how do you treat? You just observe and wait, or do you go in there with early intervention? Do you use varnishes, use flowables, do you use stannous fluoride? All of these things can help improve the oral environment so we can cut these things down so that we don't have to go in there and do full mouth reconstruction. Are all fluorides alike? We talked a little about the difference of stannous versus sodium fluoride, and I'm not knocking sodium fluoride, but when patients come in and you know that there's an acid component to what's going on, or they're getting some gingival bleeding with probing, even though they're a fairly clean mouth, you may want to start considering stannous fluoride. And the chelated form in the Crest products is the one that I recommend mostly. And we talked about what products you recommend for an acid oral environment. We talked about the type of flowable that I like from Shofu, the Beautiful X. We talked about Ceramir for the crowns and implants. We talked about some of the products from GC, like your saliva buffer kit and the varnishes and so. So that's kind of a lot of these things we chatted about. And I saw this and I'm wondering how they got all those dogs to stay in line and just wait their turn.
That's all, folks.
And these are the contact, as I said before. I know that we went through this quite quickly in a sense. This is my email at the dental school. I will try to answer any of your emails. Trust me, I will get to them eventually for sure. And Kelly Fong, if you're interested in one of the sleep residencies at the school, this is her direct connection. And I appreciate you being online today. And I know there's tons of information that came your way. My goal was just to kind of whet your appetite a little bit. And maybe have your offices trying to look at what the ADA sent out in 2017 as to what they expect us to do.
Can you comment on the trigeminy cardiac reflex? Is this the accepted understanding of the neural reaction to hypoxia?
Yes. So what happens is that when you go into the apneic situation, all of a sudden the brain is not getting the oxygenation it needs to survive. And it doesn't want you to die. So it sends a message through the trigeminal nerve down to the masseter muscle to start clenching. And as you do, you clench and clench and you wake yourself up and then you take a big deep breath. And so that is shown in the sleep studies. It shows, as I showed that one slide where the patient was going along nicely, the muscles were relaxed, but he went into that apneic episode. There was a lack of oxygenation and you saw the EMG of the masseter muscle just sky high, and it was in responding to that lack of oxygenation. So it's more and more accepted. And there's a lot of studies that kind of show that that's actually what goes on. And then once that happens, then you got to calm yourself down. And that's where the vagus nerve comes in and tries to get you back to homeostasis, because they don't want you in that fight or flight atmosphere all night. Because some of the times these people go through these episodes 30, 40, 50 times an hour. So you can imagine the stress that it has on your cardiovascular system. So yes, that is a neurological response to a lack of oxygenation, and the brain responds to it.
Why use stannous fluoride before a meal?
Well, if there's a lot of acid in the mouth, the stannous fluoride is going to close off some of the tubules, so you're not going to get less. You're going to get less and less acidic breakdown of the tooth structure itself. The worst time to brush your teeth is after you've had a meal or a drink that is acidic in nature, because now you soften the superficial enamel. Now you're brushing and you're driving that deeper down into the tubules. So the best thing to do is not to brush right after a meal. You can do a lot of rinsing with water, wait at least a half hour or so. And if you've got little kids, sometimes I joke, you know, if mothers have some cheese, they can chew the cheese. But the main thing is not to brush directly after having something acidic, either acidic meal and or a drink that has some of those acids in it that's make the surface a lot softer.
Somebody is asking about sleep residency and any info you have on that.
Yes. To legally treat patients as a dentist, you should have a sleep mini residency done. We have one at the University of the Pacific that I run with Jameson Spencer. They have one at Tufts, they have one at UCLA, and they're popping up throughout the country. And that gives you about 65 hours of additional training. And it's really important that before you start treating these patients, you have to know, A, how should I be treating? What should I be looking for? What testing should I do? How do I bill for an appliance? Because as I said, these appliances are now through medical insurance, not dental insurance. And so if you want to be paid for this, you have to know how to do all this billing. But if you try treating these patients, A, without having a sleep test done, without having a diagnosis, and not having additional training, it's just not about putting a piece of plastic in the patient's mouth. Once you put the appliance in, you have to know how to titer the appliance. Once they've been wearing it for a while, you have another sleep study done with the appliance in place to see the appliance is effective. But if they start off and they're doing well with the CPAP, then keep them on the CPAP. But these are all additional types of information that is necessary for you to, I think, stand your ground and treat these patients the way they should be treated.
Obviously, increased knowledge on OSA has indicated less use of NGs. When do you still make night guards?
Oh, I still do night guards if I feel that I see excessive wear, like, you're doing veneers and stuff, you want to protect those. But before I do a night guard, I always have them do the little sleep survey just to see, is there a possibility that they're scoring pretty high in the sleep survey? And before I do a traditional night guard, I have them see their primary care, show them a little survey, take it to them, have a sleep study done. And if it's for something very minor, a low-grade sleep study, like when you have a sleep study done, one of the responses you get are, what is your AHI, which means how many times per hour were you apneic or hypopneic? So how many times per hour were you actually stop breathing or you do a lot of snoring? And then you get a score. And the score is anywhere from 1, say, to 100. Well, 15 or less, 15 is kind of moderate. If you're down about 5 or 6, well, then you're pretty average. There's not a big problem. You can do a traditional night guard. But if you're up to 15, 16, 20, then I feel very cautious about giving them just a regular night guard, because some of the studies are showing that you can actually make their sleep worse by doing a traditional night guard. So before I do a traditional night guard, I make sure they do the little sleep study. If I pick up some idea that there's a possibility that they have a sleep problem, I do not make the traditional night guard until they have a sleep survey or sleep study done. And that's just me. Everybody can do what they wish, but that's my comfort zone in doing it that way.
Can the clenching at night only be due to stress and not the lack of oxygen?
It can be both. And it's hard to tell one or the other, but it really comes out prominently when you see EMG readings and you see that the clenching really comes out so much when they go into a lack of oxygen for the brain. And you can see it on that one study where as soon as they went to a lack of oxygen, you can see where the EMG rating just shot up dramatically within 20 seconds afterwards. So there's a direct relationship between that. Now, if there's some stress involved, it's hard to tell one or the other, but normally we really see it directly when they go into that hypopneic episode.
I have a question about the residency program, if it has to be attended in person, and can anyone do it? This person is an international dentist working as an assistant.
It's a good question. At the university, I think we've done about 5 of them now, but during the COVID, we had to cut back because we like to have hands-on. You need hands-on training to know how to do the sleep appliances, how to adjust them, et cetera, et cetera, et cetera. That's extremely difficult to do online. Over the COVID time, some schools or some residencies were actually continuing that way. But I just feel, to me, that you do need that hands-on component to really feel competent on what you're doing. So that's my personal opinion. But there are some that are strictly online, and it's up to you thinking if you learn enough from it that way. I like the hands-on bit also.
And I did thank you to the attendee that posted the link to the residency program. I did copy and paste that link in the chat box for everyone as well. I do have a couple people asking about the sleep apnea poster and where you got that.
It's C2, the letter C, number 2, C Solutions. And you can go online and you can see what it looks like, or you can order it, or I don't know if you want to just download it and copy it. But it's C2C Sleep Solutions is the name of the poster.
Okay. I have a few patients who have mandibular advancement devices, and many of them complain of either TMJ issues, changes in their bite, or lockjaw in the morning. Even with an AM repositioner, they still complain of these issues. Any suggestions on how to treat or the verbiage to use when they bring this up?
Fantastic question. Most of the changes when you're wearing a mandibular advancement appliance, stop and think what's going on. You bring the mandible forward and you're keeping it there for 5, 6, 7, 8 hours. There's a big change in the muscles and everything else. Your jaw, when you take it out in the morning, you see your jaw seems to be a little bit forward, hitting mostly on your anterior teeth. What is critical are two things. Number one, that you have a morning appliance. The morning appliance is made in your national, what we call MI, or your main bite. And you put that on in the morning until your bite goes back that you feel to where you are naturally. If you don't do that every morning, there is a tendency for these changes in your jaw position to get more and more and more with time as time goes on. Now, if there is still a problem where I'm wearing the morning appliance, A, it may not be made appropriately, or are your appliances made out of a very pliable material, which is not keeping the jaw where it's supposed to be. And even some of your MADs, if they're a pliable material, or some people go online, God forbid, they buy them online, and they're a soft boil and bite, there is a tendency for teeth shifting, contacts opening, et cetera, et cetera, et cetera. I've seen some patients that have come to me that they've treated online themselves, and they have absolutely no function on their back teeth. And I don't be sarcastic, but I said, well, go back online and see who can treat you. I mean, because they're just nightmares. They've created this problem themselves. But if you have a good appliance made with either a CAD/CAM or a high quality product, and you have a well-made morning appliance, you should not have these problems.
Okay, I am putting the C for the previous question. I'm putting the C2C Sleep Solutions in the chat box now for anyone interested in that. Next question is it enough to rinse very well before brushing after you had an acidic meal or any meal in order to avoid the erosive effect? Sometimes waiting 30 minutes might mean getting busy and not brushing at all.
The answer is yes. Most of the time, a lot of rinsing with water and stuff is sufficient to get a lot of the acid, or diluted enough to get it out of your system to be where it's really destructive, so that if you do brush, you're not, pounding it deeper into the structure itself. So yeah, I think thorough rinsing is as satisfactory. As I said, with kids, sometimes it's hard to do that. Sometimes as I said, you give them a piece of cheese, but the main thing you don't want, especially the kid, is to say, hey, you just had a meal, go brush your teeth. You want a period of time to elapse before that occurs. So, but most of the time, I think good rinsing is at least get you halfway there, if not at all.
I have been keeping contact info for patients who have also been showing signs of PTSD and other emotional trauma, since many of them displayed signs of bruxism and other sleep interruptions. Would you recommend this along with other referrals as well?
Oh, yeah. I mean, once you get into, and they have sleep studies done, then I think there's a close association of how you deal with what physician is treating their PTSD and the stress that brings into their system. Does that come out at night? Does it come out during the day? Is it nocturnal bruxism? Is it diurnal bruxism? Those things come to the forefront. But I think working hand in hand, who is dealing with their emotional concerns and say, hey, there's also a physical concern that I see going on. How can we work on this together? So I think that relationship is critical. I think one affects the other. And especially the nocturnal or nighttime bruxism has to do with oxygenation, but there's also a lot of stress too with these people. So I think, working hand in hand with the physician is really critical in a state such as this.
Are you aware of any gels that can be delivered via tray to help buffer the mouth and mitigate erosion nocturnally?
I don't know about, well, they have, that's a good question. I have to think. I know we have Perioprotect, which are trays with hydrogen peroxide, which helps dramatically with severe periodontal disease by putting the hydrogen peroxide down into the areas, into the gingival tissues themselves. If you're putting trays in your mouth, and they're wearing these all night. I don't know how that affects the effect. Is it a night guard? Is it a sleep appliance? What type of appliance are you putting it in? I don't know, because after a period of time with enough saliva, the effectiveness of the acid is washed away. So I don't know if that is needed, but they have the trays that you will know. Even some people put MI paste in them and use that at night. So I don't have a real good answer for that, but they're just some of my thoughts off the top of my head.
Okay, I think that might be it, actually. And to the attendee that just asked about not being able to copy and paste the residency program link, I will send a follow-up email to everyone registered for today's program. In that follow-up email, I will have the replay link. I will include the residency program link, as well as any other links that were referenced tonight during the Q&A session that would be helpful to everyone out there. So I think it is an hour and a half. I think we can go ahead and wrap it up. Did you have any other closing comments, Dr. Santucci?
No, I know in some areas this is a stretch, but I think it's something that fits into your practice very easily. And I didn't spend too much time with kids, but boy, if you can evaluate a child and get them off Ritalin or Adderall because they think they're diagnosed with ADHD, in essence, they're not sleeping well. And you're able, through allergy testing and other things, find out that it's not attention deficit hyperactivity disorder, but it's actually inappropriate sleeping. And through a series of either orthodontics or allergy testings and stuff, you can get them off medication for the rest of their life. That's huge. And patients appreciate it, parents appreciate it. And then there's a video, but it has to do with the kid who was attention deficit and the mother who's a hygienist. Finding Connor Deegan is the name of the video on YouTube. And that goes you through the scenario of what the child went through and how he adjusted to that. And he really wasn't ADHD, he just wasn't sleeping well. So Finding Connor Deegan is the name of that video. So that would help people a lot. In fact, some offices that do a lot with kids, they have them on little power sticks and they just hand them out to parents to watch, to think if there's a problem with their child. So to me, as a closing comment, watch our kids. Kids that clench and grind their teeth and snore, it's not a good thing. It affects the prefrontal cortex and it affects the ability of their brain to develop. So really, really critical.